Dear colleagues, my name is Thiago Reis. I am a nephrointensivist from São Paulo, Brazil, and I work at the University of São Paulo. My topic for the ISN Academy is kidney replacement modalities for the management of acute kidney injury. These are my disclosures. First, indications for renal replacement therapy. Refractory acidosis, for example, pH less than 7.20 or bicarbonate and bicarbonate less than 12. Refractory hyperkalemia, either more than 6 or 6.5 mLs per liter. Refractory fluid overload associated with pulmonary edema and anosarca, uremia, or with impaired mental status and intoxication or overdose. So, for example, overdose of methotrexate. There are mainly two modalities, intermittent or continuous renal replacement therapy. I will cover both. But irrespective of the modality, venous access is key to perform dialysis in the intensive care unit. So there is the Hagen-Poiseuille equation, which demonstrates that the resistance to blood flow has a relation to the fourth power of the radius. So small differences in the radius have a huge impact in resistance to blood flow. The unit for the diameter of catheters is French. So if we divide French by 3, we have the diameter in millimeters. So a 15 French catheter has 5 millimeters of diameter. There are different kinds of catheters with different tips. And first, an important question is whether femoral or right jugular access have differences concerning outcomes. So in this trial, it was compared the patency or of catheters depending on the site. So for catheters placed in the right jugular vein or in the femoral veins, their dysfunction was equal. However, catheters placed in the left jugular vein, they have more dysfunction. Probably it's due to this tortuous path from the insertion site through the right atrium. Another relevant question concerning venous access is where should the tip be placed? Either in the transition from the superior vena cava and atrium or inside the right atrium. Concerns about putting it inside the atrium are related to arrhythmias or perforation of the atrium. So in this trial, patients were randomized either to receive catheters of 20 to 24 centimeters to be placed inside the atrium or shorter catheters from 15 to 20 centimeters, and this would be placed in the transition from the vein to the right atrium. And the results demonstrated that the longer catheters were associated with a higher future lifespan in dialysis, so 24 versus 17 hours. And there were no more complications placing catheters in the atrium. So this is where the tip of the catheter should be placed. And here is an example. We can also access the tip of the catheter using the ultrasound. So in this case, with this incidence of insonation, we can see the catheter over here. Another relevant question is whether in different sites there is a different risk of infection. In this trial that included 637 patients, and interestingly, this trial was almost 20 years ago, and back then almost no catheters were placed using the ultrasound. So this was a prospective randomized trial, and in 12 centers in France, and patients were randomized either to get catheter in the jugular or in the femoral veins. And one of the outcomes was colonization, and there were no difference in bacterial colonization at the time that the catheter was removed. However, for patients with a BMI above 28, those patients had a higher risk of colonization in the femoral site. So this is should be taken into consideration for obese patients. And the reasons for replacing catheters in the ICU. So this data is from the AKI trial. From the femoral side, 53% of catheters were changed because of thrombosis, 29% due to suspicion of infection, and 2% of indeed proven infection. In the jugular side, 44% of catheters were replaced due to thrombosis, 42 due to suspicion of infection, and 8% of because of proven infection. So first, covering intermittent hemodialysis or prolonged intermittent renal replacement therapy. So intermittent dialysis sessions that last from 6 to 12 hours. It's important to clarify that the term hemodynamic instability is a vague term and there is no definition of instability. It's preferable to use the term refractory hypotension. It's described that for maintenance hemodialysis patients, during hemodialysis there is the phenomenon of ischemia, multi-organ ischemia, and this has been demonstrated. So even the kidneys of patients on intermittent dialysis suffer ischemia during the procedure, and there is so a reduction in the perfusion of many organs, also brain. And there are some strategies to reduce the risk of intradialytic hypotension, so reduce the risk of hypoperfusion, and this would include reducing the dialysate temperature to 35 degrees Celsius or increasing the sodium concentration up to, for example, 145, or respecting a gap between patient sodium and 6 or 8 of gap, the maximum sodium for the dialysate. So if the patient has 135, perhaps going further than 143 would be too much and could be associated with brain damage. Also, increasing calcium dialysate in the dialysate and infusing albumin before the session. And for example, in this trial in France, they utilized the sodium concentration for critically ill patients of 150. And in this trial, they were comparing patients on intermittent versus continuous renal replacement therapy. As I've mentioned prior, perhaps 150 would be too much and could be associated with brain injury. Well, I didn't mention that adjusting blood flow is associated with intradialytic hypotension, and this is not the case. There is a false belief that reducing blood flow will reduce intradialytic hypotension. This is not the case. So this figure represents the circulatory system. So here on the right, we have the arterial compartment, and 20% of the blood volume is in this compartment, and 80% of the blood volume is in the venous compartment. When we are carrying out dialysis, we are removing fluid and blood from the venous compartment, and we are giving back at the same time the same amount of blood. And for example, if we increase blood flow from 150 to 200 or 200 to 250, this is a difference of 50 mLs per minute, and the cardiac output is 5,000 mLs per minute. This is just 1% of difference. And the pump of the machine is doing the work for the heart. So the heart is not under stress during dialysis. What causes instability or hypotension or increase the risk of hypotension is ultrafiltration. So the anticoagulation for intermittent dialysis mainly is carried out with heparin, a bolus dose of 70 international units per kilogram, and the continuous infusion in general of a diluted heparin 500 units per ml. So 15 international units per kilogram per hour. In general, of this solution, 2 mLs or 1 ml per hour is enough. Blood flow. It's important to acknowledge that in critical ill patients, if blood flow is like 100 or 150 or 200, there is important risk of circuit clotting. So in this study, the bars in this figure represent the future lifespan. So see, if patient has a blood flow of 100, the future lifespan is only 10 hours, and the optimal flow would be around 250. These patients were treated with either heparin or no anticoagulations. We are not mentioning at this time citrate, not yet. Importantly, dialysate flow should not be above 400. In many centers, huge blood dialysate flow of 800 is still applied, but this does not make sense. Here in this figure, in the x-axis, we have dialysate flow, and in the right part here, in the y-axis, we have the clearance, urea clearance. Here in the right, we have different blood flows, and this curves represents different blood flow. See here in the curve representing 300 mLs per minute, if dialysate flow is 500 or around 350 mLs per minute, the urea clearance would be almost the same. So going further with the dialysate flow of 500, 600, 700 will not improve dialysis efficiency. And this will be the ideal prescription of a intermittent hemodialysis or PERT. A white catheter 13 to 15 French, a blood flow of at least 250 mLs per minute, heparin infusion, or depending on patient condition, no anticoagulation, using a high flux filter with an area above 2 square meters, because when we have larger, more area, surface area, the risk of clotting is reduced. We have less transmembrane pressure, less alarms. So the higher the filter area, the better. And dialysis flow, as I've mentioned, 400 mLs per minute, or if the patient does not require more reduction in potassium or increment in bicarbonate, only applying isolated ultrafiltration for fluid control. Now switching gears to continuous renal replacement therapy. Should we still debate on CRT versus intermittent hemodialysis? I don't think so. In many centers, we are constrained and we cannot apply continuous renal replacement therapy, but I will demonstrate in the next slide why CRT should be the preferred modality in the intensive care unit, albeit sometimes patients are well healthy enough to carry out with no complications intermittent sessions. But in general, the critically ill patient requires CRT. So this is a common scenario. Patients gets to the ICU and receives 30 mLs per kilogram of saline. Then comes the nephrologist, start furosemide, but then in the night shift, this patient develops hypertension and is given more 30 mLs per kilogram, and then this patient is drowning and we have to start dialysis. As I've mentioned prior, fluid overload is the main indication for dialysis in the intensive care unit. And a way to understand why intermittent is not so adequate for those patients, while continuous modalities might be the preferred choice, is because if a patient requires 5,000 mLs to be removed in 24 hours, If we apply a 4-hour session, we would be removing 1250 mLs per hour. If we extend that session to 12 hours, this would be reduced to 420 mLs per hour. But if we dilute all this amount of fluid that we were to remove in 24 hours, then we have a lower pace of 200 mLs per hour. And then we have a lower risk of hypotension. And this is explained in this figure. So, and imagine here, fluid overloaded patient, everything is swollen, and this inner part represents a vessel. Applying CRT with a more paced fluid removal, there is enough time for fluid from the interstitial space to refill the intravascular space. Whereas applying intermittent modalities with a high ultrafiltration rate, then the risk of collapsing of the vessels is higher and the risk of hypotension is higher. In this trial carried out in the United States with 80 patients that were randomized either to receive intermittent dialysis or continuous dialysis, there was a drop in mean arterial pressure for patients in the intermittent hemodialysis group versus no drop in patients in CRT. In the same study, for patients undergoing intermittent dialysis, 40% of them required an increment in vasopressor dose, whereas only 12% of patients in the continuous group required an increment in vasopressor dosing. And also the fluid balance is markedly different between these two modalities. Since patients in intermittent modalities are more prone to hypotension, to dialysis interruption, this is the tendency of fluid accumulation in those patients. So every day there is a increment in the amount of accumulated fluid, whereas in continuous modalities, there is this facility to remove fluid and avoid worsening in fluid overload. In this study in Canada, 290 patients, 92 patients that were submitted to intermittent dialysis sessions in the intensive care unit, they had their sessions analyzed. So in total, 1,280 intermittent dialysis sessions. And they developed two uh, ways to measure how effective the therapy was being delivered. First, if less than 50% of the planned amount of fluid was removed, this occurred in 7% of the sessions. So in 7% of the sessions, only less than 50% of the planned fluid was removed due to various reasons. And in almost 20% of sessions, less than 75% of the planned UF was achieved. And this was considered a failure. So in patients that had 3 failures or in 3 attempts in different days, attempts of carrying out intermittent dialysis, this patient failed. This is how the fluid overload occurred. So the cumulative fluid balance in 7 days of those patients that had 3 or more failures was 9 liters. And some reasons to explain why intermittent dialysis are associated with a higher risk of intradialytic hypertension. One of the reasons is the change in serum osmolality. After 1 hour of intermittent dialysis session, there is a reduction in roughly 7 mLs of osmolality, and therefore the intravascular space is hyperosmolar comparing to the interstitial space. Therefore, there is a tendency of fluid from the intravascular space to move towards the interstitial, which is hyperosmolar. So this might be one reason. Whereas in CRT, this reduction in osmolality is only 2 mLs per kilogram. And this is associated with perfusion of organs. So, for example, brain perfusion is the depends on the gradient between mean arterial pressure and intracranial pressure. When an intermittent allosession is started, there is in general a reduction in the mean arterial pressure, as I've demonstrated previously. And since now the intravascular is hypoosmolar and there is a efflux of fluid from intravascular space towards the interstitial space, there is an increment in intracranial pressure. So both phenomena converge to reduce the perfusion of the organ, both a reduction in mean arterial pressure and also an increment in intracranial pressure. Some are classic. These are classic indications of CRT. So patients requiring a lot of ultrafiltration already on vasopressors. So with refractory hypertension. In case of dysnatremias, because it's possible to customize the CRT fluid and reduce either hypernatremia or increase hyponatremia in a more paced fashion. And patients with brain edema, yes, this might be the main indications. Well, the preferred way to anticoagulate those patients is not with heparin, but with citrate. So it's the regional citrate anticoagulation. And in briefly, citrate works because it chelates, it binds to calcium ions. And as demonstrated in this figure, there is this on and off mechanism where when calcium concentration ionized is below 0.4, clotting time tends to infinite. So if we give citrate to that patient in the extracorporeal circuit and we reduced ionized calcium concentrations below 0.4 or 0.35, virtually there is no risk of coagulation. And citrate can be used in patients with active bleeding. For example, a patient with brain bleeding. It's not a contraindication to citrate because citrate does not increase the risk of bleeding in the patient. Because in the patient, the concentration of ionized calcium will never fall in these concentrations of 0.3, 0.2. This will not be achieved in the patient, only in the circuit. So citrate is established as the modality of choice for anticoagulation. There is robust evidence on that. So in this trial, patients were randomized either to receive heparin or citrate as the anticoagulation strategy. And concerning future lifespan, mean future lifespan with citrate was 47 hours, whereas with heparin was only 26 hours. So citrate is more effective and safer. In this very same study, bleeding episodes occurred in 5% of patients on citrate, but they were not due to citrate. Remember, those patients were critically ill patients and they have a bunch of reasons to develop bleeding. But in the heparin arm of the study, almost 17% of patients had a bleeding event. So citrate is safer and heparin increases the risk in 3 times of patients developing bleeding events. In CRT, we have the concept of dose, which is the amount of fluid leaving the machine or the amount of fluid being utilized either as dialysis fluid or replacement fluid, and this in relation to patient body weight. So it's not correct to apply like one size fits all and apply an effluent dose of 3000 mLs per hour. For a 100 kilogram patient, this would be an adequate dose, which is around 25 to 30 mLs per kilogram per hour. But for a patient with 70 kilograms, this would be a high dose, an unnecessary dose, and this could even be harmful to the patient because we're also dialyzing micronutrients, we are also removing antimicrobials. So it's important to tailor the dose based on patient's body weight. And when applying regional citrate anticoagulation, since citrate chelates calcium and reduce the concentration of ionized calcium, it's the replacement of calcium is needed. And here is an example in a CRT machine. So the blood from the patient comes in this part, receives citrate here, this clear line, goes in the pump, passes through the filter, goes here in the bubble trap, and then is returned to the patient. And there is an additional pump with calcium that will infuse calcium back to the patient to compensate for the amount of calcium being chelated. This is in another machine. So here, this is a piston pump. In this syringe, there is the calcium solution, and this is in another machine. So here it's a peristaltic pump for citrate infusion, and in this machine, a peristaltic pump also for calcium replacement. An important concern in CRT is hypothermia because the bags that are hanging there in the scales, they have the temperature of the intensive care unit, which is around 21 Celsius. So the patient will be dialyzed against a solution that has only 21 degrees. And all the machines, they do have this equipment embedded in general in the machine to warm the blood and prevent hypothermia. And this would be the ideal prescription for CRT in my view. So always wide catheters, 13 to 15 French, uh, regional citrate anticoagulation. So here, in this case, if the patient has a blood flow of 100 mLs per minute, with 4% sodium citrate, the citrate flow would be around 130. And I've mentioned previously that we should use high blood flows, but not when doing regional citrate anticoagulation. If using citrate, there's no requirement of higher blood flows. The circuit will not coagulate because there is citrate there. And then the blood passes through the pump, gets access to the filter, and here for a patient with 70 kilograms and dialysate flow of 1800 mLs per hour would be enough. This would give this patient 100 this dose of 108 of 1800 mLs per hour. Depending on the machine, we apply only 200 mLs per minute in the post filter replacement pump, and we would be removing, for example, 100 mLs per hour. So even ultrafiltration, it's part of the dose. So the main components of the dose are dialysate flow, replacement flow, and ultrafiltration. So for example, in this 70 kilogram patient, with this setting, applying a net ultrafiltration of 100 mLs per minute, this would give us an effluent of 2100 mLs per hour or 30 mLs per kilogram per hour for this 70-kilogram patient. Well, in the last 2 to 3 years, there is an unnecessary debate or confusion on two terms: fluid balance versus net ultrafiltration. And I'll try to clarify the difference between these two concepts. So first, fluid balance refers to the patient and is the difference of ins versus outs. So what the patient receives are ins, diet, IV fluids, and subcutaneous fluids, for example. And what get out of the patient? So net ultrafiltration, so the amount of fluid the machine is removing from the patient, urinary output, vomiting, blood losses, surgical drain output, fecal losses, perspiration, and also insensible losses due to, for example, breathing. So ultrafiltration is a concept related to the machine, whereas fluid balance is related to the patient. Well, while applying continuous modalities, sometimes we uh, we set the machine to the configuration of doing CVVH-DF or CVVH. H stands for filtration, hemofiltration. When applying hemofiltration, we either use replacement solution pre-filter here or post-filter. The amount of fluid being replaced is removed in the filter, otherwise this fluid would accumulate in the patient. So in this example, a post-filter replacement of 1000 mL per hour, this amount that is given in the extracorporeal circuit is the same amount that is leaving as ultrafiltrate from the filter. And on top of that, we apply what we call net ultrafiltration. So it's the amount of fluid that is being removed from the patient. And in this example, I placed here 200 mL per hour. So each hour we would reduce the patient fluid balance in 200 mLs in this configuration. So this is net ultrafiltration. The total ultrafiltration also includes pre or and post-filter replacement. So once again, fluid balance is the difference between gains and losses. And in the part of the gain domains, we have diet, IV fluids, subcutaneous infusions, and losses, urine, vomiting, so on and so forth. And here we do have the net ultrafiltration. The confusion in the literature is because some authors are referring to fluid balance as net ultrafiltration, which is not adequate. And finally, the discontinuation of the therapy. In this trial in Germany, patients requiring renal replacement therapy had their urinary output measured. So after 3 days from the start of CRT, if urine output is more than 436 mLs per day, these patients have a probability of being out of dialysis of more than 60%. So here, for example, at 10 days, patients that on day 3, they were urinating more than 400 mLs per day, they do have the risk of or the probability of being out of dialysis of 60%. For patients that had a urinary output less than 436 mLs per day, in the same 10 days, this was only around 30%. So at day 3, urinary output is a relevant marker for dialysis dependency. But what I think is the most effective way to predict see therapy liberation or discontinuation is the furosemide stress test. So in this test, 1 milligram per kilogram of furosemide is infused in bolus, and after 2 hours, the urine output is measured. So in this trial in China, 55 patients on dialysis, they were submitted to the furosemide stress test. And the best cutoff value was 188 mLs after 2 hours of urinary output. In this cohort, 45% of patients were still CRT dependent, and 55% were free from dialysis. And if patients had a urinary output less than 188 mLs, there was a accuracy of 0.91 or 91% accuracy of affirming that those patients would still require dialysis. Whereas patients that had a urinary output above 180, there was also this discriminatory ability to predict that this patient will not require dialysis. So this is an elegant way to distinguish groups of patients that are either prone to still require dialysis in the following days or are likely to recover partially kidney function. So I am available. It was a pleasure being here in this activity from International Society of Nephrology, and uh, I hope you follow me in social media and interact with me. Thank you so much.